Good day, everybody. We will be starting this webcast in about 2 minutes. Good morning, good afternoon, good night, everyone, wherever you are. Thank you for joining us in another Webinar Wednesday program, today co-organized and co-sponsored by Medtronic and Philips. Today's webinar will be dedicated to discussing the topic of respiratory compromise, use of capnography, a common, costly, deadly, but preventable. Sorry for the confusion. My name is Dr. Yuste, and I will be acting today as your moderator. In doing so, I will receive your questions and try to answer as many as we can at the end of the event. Today's webinar is going to be accredited for physicians through ACCME, nurses from the California Board of Nursing, and RTs from the American Association of Respiratory Care. At the end of the presentation, we'll share with you a link where you can go to obtain your CE certification. During the event, questions can be sent through the questions panel on your screen. Feel free to send your questions, and we will try to answer as many as we can at the end of this lecture. With that, I will introduce our speaker today, Brian Berry. He currently serves as the Assistant Chief Nurse Anesthetist and Director of Perioperative Services at Excella Health, a 5-facility system located in Western Pennsylvania. At Excella, Mr. Berry is responsible for leading the operational, financial, and strategic goals of both anesthesia and perioperative services. Mr. Berry is adjunct faculty at the University of Pittsburgh, where he provides didactic instruction on various subjects such as simulation, pharmacology, obstetrics, and regional anesthesia. Mr. Berry has lectured at both national and international continuing medical education conferences and has published in the Wall Street Journal, USA Today, American Association of Nurse Anesthetists Journal, International Journal of Clinical Anesthesiology, among others. He has served on the American Association of Nurse Anesthetists Public Relations Committee and has been both a Board of Trustee member and the Vice President of the Pennsylvania Association of Nurse Anesthetists. Mr. Berry's education includes a Master's in Science from St. Vincent College and Master's in Business Administration from Waynesburg University. Most recently, Mr. Berry has been named Excella Health's coordinator of the Safety Program for Improving Surgical Care and Recovery, ISCO, an activity in conjunction with the Agency of Healthcare Research and Quality, AHRQ, Johns Hopkins, and the American College of Surgeons, ACS. Among a multitude of awards, Mr. Berry was recently recognized in Pittsburgh Magazine in 2017 for distinction among advanced practice providers. With that, please welcome Brian Berry.
Thank you, Fernando, for that outstanding introduction. I'm pleased to be here with you today to present a topic that I'm incredibly passionate about. I've entitled it Respiratory Compromise, Common, Costly, Deadly, but Preventable. And we'll get started. Let me just try to take control and advance the slides. Here we go. Sorry for the webinars are always interesting when you're transferring power from one person to another. And those of you that have done webinars, I'm sure you understand that. So I've got control now, and these are my disclosures that I'd like to notify the audience about. And here are the objectives for today. We're going to cover a lot of ground in the course of the next hour. The first objective is to discuss the importance of improving our current respiratory compromise prevention paradigms. Number two objective is to define respiratory compromise, including the patient pathway and clinical objectives at each phase. Number three is to assess major literature on continuous pulse oximetry and capnography monitoring. Number four is to list the 3 physiologic pathways that lead to respiratory failure and arrest. Number five, to discuss the reliability, response time, and accuracy of monitoring options. Number six is to recognize how capnography waveforms can provide an indication of the quality of a patient's ventilation. And finally, number seven is to recognize the importance of early recognition and intervention in respiratory compromise. So we're going to cover a lot of ground today. Okay. I'm going to warn the audience that we're going to start with a sobering story. A couple stories. In fact, there was pictures of them on my title slide, and these patients have stories, those pictures on that title slide, and I'm going to share those stories with you. Once again, this is going to grab the audience's attention for sure, and show you the gravity of the problem of respiratory compromise. So the first case study, if you will, I want to tell the audience about is a patient by the name of Leah Kufal. She was 11 years old, and she was getting a repair of a convex projecting sternum, not terribly uncommon in the pediatric population. So Leah underwent a successful surgery, got discharged to a postoperative general care floor, and Leah started complaining of pain, and she was given fentanyl repeatedly. She started becoming less alert but agitated. She was given Ativan for anxiety. And at about 1 a.m., her mother, Lenore, was exhausted, as a lot of patient family members are after being with a loved one for a long time, took a nap, and at 2 hours later, at 3 a.m., Lenore, Leah's mother, awoke and found her daughter, Leah, dead in her bed. Terrible tragedy. Lenore, Leah's mother, was quoted in saying this: "Would real-time monitoring have saved Leah? That is one of the many questions that I've asked myself every day since I found my daughter Leah dead in her bed. The answer is yes, it would have." The second case study that I'd like to present, Mr. Logan Parker, he was also on the title slide, his picture. He was 17. He was diagnosed with obstructive sleep apnea, not terribly uncommon in pediatric and adult population, underwent a routine procedure that treats obstructive obstructive sleep apnea. He had his tonsils and uvula removed, and he also had his septum and turbinate repaired. Once again, a successful outpatient procedure. After the procedure was over, Logan started receiving IV morphine, 1250, 1253, and 1310 in the recovery area. His IV was actually removed 8 minutes later, and he was discharged at 1325. On his way home, Logan started becoming a little less responsive during his drive. And then once home, he stopped breathing. Logan's mother was a PACU nurse, and her friend was also a registered nurse, and they started CPR, transported Logan via paramedics to the emergency department. Unfortunately, Logan was pronounced dead after unsuccessful resuscitation with his mom on the way and in the ED. This is what Pamela Parker said, the PACU RN, the mother of Logan, said. All patients receiving opioids should be continuously electronically monitored. Do not rely upon pulse oximeters. Monitor with capnography. Those are just two examples of the hundreds of thousands of folks that tragically lose their lives every year due to respiratory complications. Our whole goal in this lecture today is to prevent these tragedies from occurring at our facilities. So let's start with defining respiratory compromise. For those of you in the audience that aren't familiar with the term, I'm going to define it for you. According to the Respiratory Compromise Institute, respiratory compromise is a deterioration in the respiratory function in which there is a high likelihood of respiratory failure or death, but for which timely, specific interventions such as enhanced monitoring or therapies might prevent or mitigate decompensation. Sorry, looks like the presentation backtracked the sensitivity of the webinar. The second bubble is paramount to the audience. I cannot stress the second bubble enough. What this says is it's critical to identify patients in respiratory compromise the instant when they develop that. And if you intervene at the appropriate time, you can avoid catastrophic events. Respiratory, this slide represents the motivation for the title slide. It's common, costly, deadly, but preventable. Let's talk about how common the problem of respiratory compromise is. According to Agrawal and colleagues, nearly 12% of all adult elective procedures and 7% of all Medicare patients will experience respiratory compromise. It's the leading cause of ICU admissions, rapid response team calls, and code blue calls. Now, you may be scratching your head, and some of you in the audience may be scratching your head and saying, you know, Brian, we're in 2019, 2020 healthcare, aren't we getting a lot more safe? Well, in many ways we are, but not with respiratory compromise. And once you dive into the details a bit further, it isn't all that shocking. You know, two factors that pop in my brain instantly that contribute to that commonality of respiratory compromise is patient's age. You know, we're living longer than we ever have before. And with advanced age, it's directly proportional to a person's potential in developing respiratory compromise. The second factor that pops in my brain is weight. We all know that the obesity epidemic in the United States and even arguably globally have contributed to a patient's ability or potential to develop respiratory compromise. So those two factors alone have greatly contributed to this common problem. It's a costly problem. Back in 2007, we spent $7 billion in respiratory compromise. And now in 2020, in fact, this researcher said last year, now we just transitioned to 2020, we're spending $37 billion We've seen a $30 billion increase in the problem of respiratory compromise. A patient that experiences a respiratory compromised event on a general care floor can expect to stay 7 days longer, and a patient that experiences a respiratory compromised event on a general care floor can expect an additional 3 days. On average, those unanticipated increased length of stays will cost us around $18,000 to $30,000, depending on which literature you read. And I can assure the audience, directors of finance, chief financial officers, etc., have their eyes on respiratory compromise affecting their bottom lines. So you can take a positive hospital profit margin, have several patients experience respiratory compromise, have them have unanticipated increased length of stays, and really impact your profit margin. It's a deadly problem. I shared the stories of Logan and Leo with you. You can read the factoid right in front of you. Patients with respiratory compromise originating on the general care floor are 29 times more likely to die than those that don't. Those that have been in the healthcare profession for a number of years, I'm sure, have their own stories, like Logan and Leah. I have a few of my own personal stories where I think that if we properly identified and intervened in patients, tragic consequences wouldn't have occurred. And this is why this topic is so passionate of mine. Now, the silver line, we started the topic today on a very serious note, but the good news, and here's the positive spin on today, it's preventable. And I'm hoping this entire audience will walk away better educated and more informed to prevent respiratory compromise at our facilities. Look at the research in front of you. Nearly 2/3 of primary respiratory arrest are classified as potentially avoidable. I've seen other studies that say up to 73% of the time respiratory compromise is preventable. So I submit to you today that we can do a better job. Now, there's risk factors for respiratory compromise, and I'd like to share those with you today. There's patient factors, there's treatment factors, and area care factors. Let's start with patient factors. We did cover those a little bit, and these are just a few to name a few. Body mass index. Of course, if a patient is of a high body mass index, or they have advanced heart disease, lung disease, have those significant comorbidities, they would be at an increased risk for respiratory compromise. There's treatment factors, such as previous anesthesia, patients on opioids, patients on any type of respiratory depression, getting sedation. So there's treatment factors as well that contribute to a person's potential of getting or experiencing respiratory compromise. And then there's area care factors, such as patient to nurse ratio. What is your hospital and facility's protocol to monitor vital signs? How are you doing spot checks? What is your protocol or your guideline at your facility? Now, so all of those things impact patient factors, treatment factors, area care factors. Where you really get into dangerous territory and what we call the perfect storm is when you combine those. So we're talking patient factors, treatment factors, and area care factors all going against you. It's not a matter of if, it's when a patient is going to go down a catastrophic algorithm to a respiratory insufficiency failure and potentially death. So looking at risk factors for respiratory compromise a little bit more in depth, the subsection that is everywhere in the literature, you merely need to open up a journal really, is opioid-induced respiratory depression. It's everywhere. And you can look at what research is saying that are patient risk factors, and I'm not going to read them word for word for you, but you can see things like sleep apnea, morbid obesity, older age, which we've mentioned, post-surgery, and so on and so forth, greatly contribute to a patient's potential for experiencing respiratory compromise. Another subsection that I'd like to review for you is patients that are receiving procedural sedation. current research says that choice of sedative itself, over-sedating a patient's American Society of Anesthesiologists physical status, obesity, and so on, will impact a patient's potential for experiencing respiratory compromise. So these are kind of subsections of risk factors for patients experiencing respiratory compromise. Now, according to the Anesthesia Patient Safety Foundation, what they are one of the respected foundations in anesthesia, what they say is selective monitoring based on risk assessment is likely to miss respiratory depression in patients without risk factors. So in other words, the Anesthesia Patient Safety Foundation is telling the audience, these risk factors in the dark blue and light blue are very important, and they're going to risk identify high risk patients. But if a patient doesn't disclose to you that they've been diagnosed with obstructive sleep apnea, if they don't disclose to you that they've had past anesthetics or sedation where their airway has been compromised, you may miss it. If you only look at the risk factors themselves, you may miss it. And we're going to go over that here as the presentation continues. I'd like to review with the audience the respiratory compromise cycle. And this is really what occurs even in 2019, 2020 healthcare, right? We just transitioned to 2020. This is really how we function. We have a patient with a risk factor. It could be a patient, area of care, or a treatment factor. They experience respiratory insufficiency. They then go into respiratory failure and arrest. We manage that failure in some way, shape, or form, and hopefully we manage it successfully and they get to transfer home. Our clinical objective today, and I want to impress upon the audience this here, is doing a better job, is changing how we do things, changing that circular cycle that we just reviewed. We're going to identify risks, and we're going to be educated on risks that we just reviewed. We're going to intervene quicker. We're going to prevent this from occurring, but we're going to recognize patients the instant they experience respiratory compromise. We're going to intervene, and we're going to prevent that insufficiency, failure, and arrest from even occurring. That is what our goal is today. So many conditions do cause respiratory failure, and there may be some rhetorical or some questions that the audience may be asking. Maybe some of you are wondering, hey, Brian, how do I monitor a COPD patient versus a pneumonia patient versus a post-op or heart failure patient to provide this early identification that you're discussing? You may be asking, how does monitoring guide early intervention? Those are all good questions, which we're going to answer. But before we do that, we have to review 3 physiologic pathways that lead to respiratory failure. The first, Curry described as hypoxemic or type 1, otherwise known as oxygen type failure. For the audience today, I have a clinical scenario that's an example of oxygen failure in front of you. And kind of portrays what occurs. And then the subsequent slide will show a diagram of what occurs in oxygen failure from a vital sign standpoint. So an example of type 1 or hypoxemic or oxygen failure would be a healthy male who had just undergone an elective surgery, started developing shortness of breath. That's noticed by his family, and they express concern to the nurse. The nurse, citing a normal oxygen saturation reading on his oximeter, reassures the family that he's doing fine. Eventually, his respiratory rate rises to a critical value, but by this time it's too late to effectively respond to his rapidly deteriorating clinical condition, and the patient with sepsis dies. Here, I'd like to direct your audience attention to the left side of the screen, the diagram in front of you. This is the illustration that correlates with oxygen failure. This is what occurs in our patients that experience respiratory failure. So as you can see, patients start their oxygenation start declining. To compensate, the light blue line is your respiratory rate, and the dark blue line is your minute of ventilation. So to compensate for this decreased oxygenation, patients increase their respiratory rate. And by definition, your carbon dioxide decreases when your respiratory rate increases, right? So they compensate for a while, right? You can see the y-axis is the numeric value of these monitoring modalities, and the x-axis is time. So they compensate for a little bit, but then on the right side of your screen, these patients go into full-blown respiratory failure and arrest. And what's been more and more in the literature, and you merely need to do your own peer-reviewed published article research, or Google. I've given variations of this lecture all over, and nationally and internationally, and take out your Android or iPhones right now and Google it. It's everywhere. Supplemental O2 will further mask this type of respiratory failure. What happens is the curve is shifted up and to the right. Patients sustain normal to near normal oxygenation for a longer period of time. Meanwhile, if you do not properly monitor these patients behind the scenes, they are in full-blown failure and arrest. This is classic of patients with pneumonia, ARDS, sepsis, and heart failure. The next type, Curry and colleagues described as hypercapnic failure, or type 2, otherwise known as ventilatory failure. Here's what ventilatory failure, an example, could look like. A healthy female who is receiving routine post-op nasal oxygen has been up all night complaining of severe post-op pain, but is now finally asleep after yet another dose of IV opioid. The nurse, noticing on rounds that the patient's oxygen saturation is perfect, decides not to awaken her. She is found dead in her bed 4 hours later. I've seen examples of real-life examples of this situation, completely avoidable. This is the diagram that correlates with type 2 or hypercapnic or ventilation type failure. So what happens with these patients, right? The light blue line and the dark blue line are the respiratory rate and minute ventilation respectively. What happens is these patients get some sedatives, right? They get opioids, benzodiazepines, they decrease their respiratory rate. By definition, their carbon dioxide increases, the teal line. And they compensate for a while, just a short while on this one. The y-axis is time. So they conserve energy, they decrease their respiratory rate, they can conserve some energy, but then their the oxygenation plummets. With, like type 1, type 2 with supplemental O2 is susceptible to that mask phenomenon. Again, do your own peer review published research. Supplemental O2 masks type 2 ventilation type failure. What happens is the curve is shifted up and to the right. Patients sustain normal to near normal oxygenation for longer periods of time with supplemental O2. Meanwhile, if you're not properly monitoring your patients, they can be in full-blown failure and arrest. This is classic of patients receiving opioids, sedatives, brain injuries, and so on. The third example Curry described was arousal or type 3 failure. This is otherwise known as sleep disordered breathing. An example of sleep disordered breathing failure is the one before you here. An otherwise healthy male with unrecognized sleep apnea receives post-op opioids. His alarm sounds repeatedly, but only lasts for about 30 seconds before it stops, only to repeat again and again and again. When the nurse awakens the patient, he feels fine and is completely alert, says, "Stop waking me up." He asks for more pain medication and the nurse gives it. The nurse, suffering from alarm fatigue, stops responding to the same alarm. Later that night, the patient is found dead in bed. And we all know the Joint Commission's Sentinel Event Alert about alarm fatigue. This is very serious problem. So arousal type failure, type 3, or sleep disordered breathing, the illustration in front of you shows you what occurs in these patients. what happens? So the patient starts obstructing, and we know people with this. This is classic of obstructive sleep apnea patients. What happens is they obstruct, their oxygenation, the orange and yellow line declines, their carbon dioxide increases. So what do? Their chemoreceptors of their carotid and aortic bodies signal to their brainstem to awaken and to restore normal oxygenation and ventilation. So they wake up, they unobstruct themselves, only to fall right back into that sawtooth or sinusoidal pattern, if you will, of respiratory failure. Now, I'll warn the audience, this type of sleep disorder breathing type failure, you give patients that suffer from this opioids or potentiate this problem, they could obstruct quite impressively and can be very hard to rescue. Once again, classic of those OSA patients. So those were the three types of pathways or clinical pathways to for patients to get respiratory failure. Now, I'd like to shift gears in the prevention portion of our lecture. I tell audiences all the time, the best way to learn is from the past, studying history. And I thought the best way to do that today was to review the American Society of Anesthesiologists closed claims analysis on postoperative opioids and sedation. The ASA looked at lawsuits and analyzed the data and look at what they found. The light blue bubble to your left, respiratory depression was identified in 92 claims, of which 77% resulted in severe brain damage or death. 88% of respiratory depression events occurred within the 24 hours of surgery. That's one I really want the audience to remember today, because just because, remember Logan, just because the procedure's done, just because they've been discharged from the PACU, just because they're on the general care floor, doesn't mean that they're at no risk for respiratory events. And the orange bubble is the most important, I think, from the ASA closed claims analysis. 97% were judged as preventable with better monitoring and response. And I'm going to repeat that one for the audience because it's that important today. 97% were judged as preventable with better monitoring and response. And then you can see the last bubble there. The time between the last nursing check and discovery of the patient with respiratory depression was 2 hours and 42% of claims, and 15 minutes and 16% of claims. So response time is a big deal. What else did the ASA lawsuit analysis reveal? Well, they looked at sedation outside the OR, and it's a high-risk area, right? Those of you in the audience today that work in the interventional radiology suite or the gastroenterology suite or give MRI sedation, CT sedation, these are high-risk areas. And what the ASA said was that 62% of claims from over-sedation were judged to be preventable by better monitoring in these areas. So I challenge you guys at the end of this presentation to that do not properly monitor your patients to do that. They also looked at sedation and monitored anesthesia care. And for the audience members that don't know what MAC anesthesia or monitored anesthesia care, it's when a patient has an unprotected airway. So they're not intubated, they're breathing on their own, usually unaware of their surroundings. And what they found here was after an overdose of sedation meds, respiratory depression was the most specific damaging mechanism in MAC claims. Nearly half of these claims were judged as preventable by better monitoring, including capnography, improved vigilance, and audible alarms. So the history says we need to monitor better, we need to intervene quicker. That's what the closed claims analysis says. Let's look at some big meta-analysis, new literature that has come out looking at capnography monitoring, pulse oximetry monitoring, and looking at massive studies The purpose of this one was to review the effectiveness of the pulse oximeter and the capnography in relationship to respiratory compromise. The methods this was a systematic review, meta-analysis looking at adults receiving opioid analgesia following surgical procedures that had continuous pulse ox and or capnography. You can see the outcomes. They looked at the authors of this literature, looked at oxygen desaturation, bradypnea, or otherwise known as a low respiratory rate, hypercarbia, or high carbon dioxide, rescue team activation, ICU admission, and mortality. Now let's look at the results and conclusions. 9 studies met this criteria. Capnography alerted clinicians to postoperative respiratory depression earlier than the pulse oximeter. And the authors wanted to note that this is particularly important in patients with supplemental O2. Another conclusion of the authors was that the pulse oximeter improves detection of oxygen desaturation compared with spot checks. So in other words, you need to continuously use it. There were trends towards reduced ICU admissions with continuous pulse oximeter. The next multi-center meta-analysis was looking at capnography monitoring. This looked at 13 randomized controlled trials that were published between 2006 and 2016, compared capnography monitoring with just the standard of care monitoring. So those centers that did not include capnography monitoring with those patients receiving procedural sedation. And look at what they found. The meta-analysis of the 13 randomized controlled trials indicated that the addition of capnography was associated with less mild oxygen desaturation, severe oxygen desaturation, and the need for assisted ventilation. So the authors strongly indicate that the standard of care needs to change and the addition of the capnography monitor needs to occur. So at the end of the day, don't take my word for it on how to monitor these patients. Take society, take the major professional organizations and societies' word for it. We'll start with the Joint Commission. What do they say? How do they say to monitor these patients? They say that the pulse oximetry is used to monitor oxygenation. The capnography monitor is used to monitor ventilation. 2 different things. Educate staff to not rely on the pulse oximeter alone, because the pulse oximeter can suggest adequate oxygen saturation in patients who are actively experiencing respiratory depression, especially when supplemental O2 is used. Thus the value of using capnography to monitor ventilation. The American Society of Anesthesiologists says you need to monitor oxygen saturation levels, carbon dioxide levels, and levels of sedation. The Anesthesia Patient Safety Foundation says that capnography and or other monitoring modalities that measure the adequacy of ventilation and airflow is indicated when supplemental O2 is used. Then the American Society recently did a multi-society position statement. They got, I think, people like the American College of Surgeons, the American College of Obstetricians and Gynecologists, and so on and so forth, and they came up with a position statement together, these 6 very respected societies, and they said, continually monitor ventilation function with capnography unless precluded or invalidated by the nature of the patient, procedure, or equipment. Continuously monitor all patients by pulse oximetry with appropriate alarms. It doesn't get any more black and white. And I can tell you, in anesthesia, it's a standard of care now. So anytime a person is administering anesthesia, they have to use the capnography monitor. And I'm not going to read the rest to you, but the European Society of Anesthesiology has put out a position statement. The Society of Gastroenterology Nurses and Associates, the SGNA, who I've had the pleasure of speaking at their national meeting many times, have put out a position statement on this topic. the Association of Radiology and Imaging Nursing, the American College of Radiology, the Society of Interventional Radiology have all put out position statements regarding this topic that we're discussing today. There's a growing wave of capnography position statements, standards, and recommendations from societies. Look at this. In the last decade, and I need to put 2018 and 2019 up there now, there's been a host. There's been something like 67 or 70, and please don't quote me on that exact number, but there's been tens, almost 100 position statements, standards, and recommendations on this topic. I've split these up into years, and you can see the dark blue is the U.S. and North American position statements, the orange is Europe, and the teal color is the other. I further split this up. The purple is position statements and recommendations and standards that have to do with sedation, and then the yellow is positions and recommendations that have to do with opioids on our topic today. Okay, I want to review with the audience ideal monitoring. What are we talking about specifically today? This is one of my favorite slides of the entire presentation. It's very busy. Sometimes it can be intimidating for audience members, but bear with me. We'll go through it together. This was adapted from the Anesthesia Patient Safety Foundation, one of the most respected entities in anesthesia. And I'd like to orient you to it right now. So if you look at the first column of the diagram in front of you, it's the monitoring modality. Then the subsequent 4 columns are the sensitivity, specificity, reliability, and response time of that modality to monitor a person's respiratory function. So let's start with a skilled and non-skilled clinician. Okay, so when a non-skilled clinician assesses a person's respiratory function, they don't do a very good job. This is an example of this would be a hospital volunteer taking a patient through a wheelchair throughout the hospital, right? Well, they weren't trained and they don't really know. So as you might suspect, the sensitivity, specificity, reliability, and response time is low and slow. How about when you or I, with a naked eye, look at a patient and assess their respiratory function? Well, you know, we do a little bit better job. We were trained. Our sensitivity, specificity, reliability jumps up to a moderate level. Our response time is still slow. You then add modalities such as respiratory rate, tidal volume, chest wall impedance, and we really don't get any better from a sensitivity, specificity, reliability standpoint. In fact, we jump down a little bit, but our response time gets a little bit better. It jumps up to a median level. We then add the modality of the pulse oximeter monitor. Without supplemental O2, the pulse oximeter does a good job of monitoring a patient's respiratory function. Sensitivity, reliability is high, response time is fast. However, with supplemental O2, the pulse oximeter is a poor indicator of a patient's respiratory function. A major point of emphasis in this lecture today. Notice how the response time is slow, sensitivity, specificity is moderate level. We then transition to carbon dioxide monitoring, especially in the intubated, non-intubated patient. Look at the results here. In the unintubated patient, sensitivity, specificity is high, response time is fast. In the intubated patient, it doesn't get better, right? It's high, it's high and fast. So my point to you today, to the audience, please add the carbon dioxide monitor to your patients that are experiencing respiratory depression or are at risk for respiratory depression. Okay, to finish out our lecture today, I want to go over some waveforms, especially for the audience members that have not used the EndTidal CO2 monitor. It can tell you a lot about a patient's breathing just by looking at the morphology of the waveform. So let's go over some waveforms of the EndTidal CO2 wave or the EndTidal CO2 monitor to orient those audience members that aren't familiar with this technology. All right, I always tell, I'm adjunct faculty at the University of Pittsburgh. I do a lot of guest lecturing at schools of nursing, schools of nurse anesthesia, respiratory therapists, and so on. So I always tell students and even clinicians, know normal, because if you know normal, then when something is abnormal, you know it's not normal. So this is the normal tracing of an EndTidal CO2 waveform. It is a indirect measurement of PaCO2. So normal values would be 35 to 45. And the flat line against the bottom of the screen is what we refer to as dead space or expiration dead space. The upstroke is the beginning of expiration. The horizontal waveform is exhalation plateau. And then if you want to look real smart in front of your clinicians, you can point to the right side of the mountain on the diagram of the little square, the right tip of that mountain, and that's where the EndTidal CO2 numeric value is derived from. And then the downstroke is inspiration. So that is kind of the morphology of the waveform, and really impress upon your brain this normal image, because we're going to go over now some abnormal images. So this is an example of apnea, one of the most important to understand, right? Because the patient's exhaling the first breath pretty okay, but then the subsequent 3 breaths are very suppressed, and then ultimately there's no breath at all. So this patient's apneic, they're not exchanging, and they are experiencing severe apnea. And you need to call for, in this clinical scenario, you need to call for help. This next one is partial airway obstruction. This next one is partial airway obstruction. As you can see, a patient takes a normal breath followed by 3 subsequent suppressed breaths, and you need to intervene. So what we're seeing here is this patient probably needs a jaw thrust maneuver, or an oral airway inserted, maybe a nasal airway, but they're experiencing partial airway obstruction. They're not fully expiring carbon dioxide. The next diagram in front of you is what we call hypopneic hypoventilation. What occurs in this patient here? This patient has a normal exhalation followed by 3 suppressed ventilations. And what happens? Their CO2 climbs in their body. Their chemoreceptors of their carotid and aortic body signal to the brainstem, hey, blow off all this excess CO2. And as you can tell, they blow out all that extra CO2, and they restore normal oxygenation. Finally, there's hyperventilation, and this one's very simple. This patient, this example in front of you, is a patient that is hyperventilating. They're breathing very fast, and you can see that the numeric value, if there was a numeric value below that 45, they'd be more like 35 or 30. So they're blowing off CO2 quite quickly, and they're breathing quite fast. So this is an example of hyperventilation. So those are some examples to orient the audience to what EndTidal CO2 can do for you, what it can teach you, and how you can just look at the morphology of the waveform and know how your patients are breathing. I want to finish up the presentation with a strong emphasis with the audience to consider remote monitoring. And those of you familiar with remote monitoring, thank you for doing this. And those that are not, I hope to talk a little bit about it. I recently talked to a nurse who implemented this in Hawaii, and she was so ecstatic that her organization decided to do this. So what remote monitoring is you have a central station where this central station is collecting patient data, and you can actually, technology can even link this into your phones and other devices, and it will tell you when alarms are going off, when to escalate, and so on. So this remote monitoring is collecting all this patient's data. Let's say that you're on a general care floor where there's high patient to nurse ratios. This can be extremely advantageous. It has alarm managing capabilities. It can give you reports, sophisticated reports. You can do things like what if scenarios, if alarms change. You can do a lot of education with these remote alarms with this newest technology. And then finally, there's clinical decision support that is capable with this newest technology. There's smart alarms. You know, there's monitors out there that look at the respiratory rate, the carbon dioxide, the pulse oximeter, and the blood pressure, sends those 4 numeric values in an algorithm and tells you how the patient's doing, taking those four parameters into consideration. It allows for integration with electronic health record and other devices, and it really is involved in what literature is indicating, early warning scores. So when these patients are on just the brink of deterioration, it'll tell you well before a patient completely deteriorates. So very, very cool stuff. This is the future of healthcare. I firmly believe it. I think remote monitoring is going to increase patient safety, and we'll see a substantial improvement in patient outcomes because of this. I'd be happy to talk more about this after the presentation. And you can see the orange bubble here. If you're not remotely monitoring your patients, you are simply spot checking a continuous monitor every time. Exactly. So using that general care floor example. So if you have 6 patients on a general care floor, but you have them on continuous monitors, but you only peek your head in every once in a while, every 2 hours, they're on a continuous monitor, but you're only spot checking that continuous monitor. If you don't have that remote monitor available in that central station, you're just simply spot checking. So the summary today, what do I want to leave the audience? Respiratory compromise happens frequently at a great cost to the healthcare system with a high mortality. Respiratory compromise is often preventable when recognized early to trigger early intervention. There are 3 physiologic pathways which commonly lead to respiratory failure and arrest. Understanding these pathways can guide clinicians in the selection of monitoring technologies. Continuous monitoring of capnography and oximetry can provide clinicians with early identification of evolving respiratory compromise, allowing early intervention that may prevent tragic consequences. And that last one is the take home. Early identification, early intervention that will prevent tragic consequences. And with that, I thank the audience very much for their time. These are the references for the presentation today, and I'll gladly take some questions. Thank you.
Thank you very much, Brian, for this great presentation. Now we are going to open it to questions and answers. But before that, I want to share with you where you can actually obtain your CS certification. You will to fulfill a couple of requirements there, but after that you should be able to get your certificate. Also, some people have been asking if we're going to give a handout of this presentation. We will gladly allow you to download it from this site, or otherwise just send us an email and we will do so. With that, I'm going to move into the question and answer part of this event, which actually ends the C accreditation section. So we will move to open questions and answers. I'm going to start with first question from Patricia. Thank you, Patricia. She says, I have been in the field over 40 years and believe the rise in unrecognized respiratory compromise is directly related to cuts in staffing that do not allow more frequent monitoring. What are your thoughts or feelings?
Can you repeat that one more time, Fernando? I didn't catch the middle part. I heard
Yeah,
that
absolutely.
this individual was is in the healthcare industry for quite a while, and then I missed the middle.
Yeah, and she says
what was
that
the question?
she says that she believes that respiratory compromise is directly related to cuts in staffing that do not allow more frequent monitoring. What are your thoughts or feelings?
Absolutely. I cannot agree more. I think that a major risk factor is that we're not monitoring these people frequently enough. This urge, and if you saw, the major theme in the presentation today was to continuously monitor end-tidal CO2 and pulse oximetry monitor and respond in an effective time. So yeah, I completely agree. I think guidelines and standards need to change. Many organizations are putting out these position statements. I think hospitals and facilities need to change their policies on monitoring vital signs, and I think we'll see major improvement in patients.
Another question comes from Narina. Narina is asking, are the levels of RD you described only applicable to patients on opioids?
Repeat that question one more time too.
Yeah, are the levels of respiratory depression you described only applicable to patients on opioids?
No, absolutely not. Opioids are clearly a high risk area for patients to develop respiratory compromise, but as the presentation highlighted, patients with obstructive sleep apnea, patients with advanced age, patients that are in areas of care where they remember that patient factors, area care factors, treatment factors, patients on anxiolytics. So there's a host of other patients separate from opioids that are at a risk for respiratory compromise. Now, obviously, opioids gets the most attention and deservedly so, but no, patients that are post-procedure, maybe a big push in anesthesia is doing opioid-free anesthesia. So opioid-sparing techniques. Patients still getting sedatives would be at an increased risk for this.
Now the question is, we have found tracked ventilated patients without a cuff need to have TCOM instead, as the ambient CO2 to alveolar CO2 gradient increases and tidal CO2 becomes less accurate.
Say that one more time. Sorry, I'm making you repeat the questions twice. I just need to hear them again. What was that?
Yep, we have found tracked ventilated patients without a cuff need to have TCOM instead, as the ambient CO2 to alveolar CO2 gradient increases and tidal CO2 becomes less accurate.
Oh, I see. We're talking about the ambient wash of end-tidal CO2. Yeah, that's a very important point, and usually during presentations I do point that out. So end-tidal CO2 in a non-intubated patient, you are trending. I mean, similar to even, I would argue, the pulse oximeter. So if you connect a pulse oximeter to a patient and it's 95 on room air, chances are that patient lives at 95. That's their baseline. That's where their pulse oximeter lives at. Similarly, if you put a nasal cannula on a person that has end-tidal CO2 capability and they're trending at a 30 millimeters of mercury and their waveform looks a little suppressed, that's their baseline. So it will not look perfectly in some patients because it's not an intubated patient. So yes, that is a very good point, that you are trending an end-tidal CO2 waveform in patients, just like you would trend other vital signs. So very, very important point. Glad that was mentioned.
So we have time for a couple more questions. Max, thank you for praising the presentation. And Max is asking, can you address telehealth and long distance monitoring of patients?
Yeah, absolutely. That kind of goes in with that last point, that remote monitoring. You're going to see in 2020 healthcare and beyond, you're going to see a big push on remote monitoring, telehealth monitoring. I think, some of us have devices that are monitoring our heart rate and EKGs remotely. My dad has a pacemaker, and the cardiologist can tell when the pacemaker isn't functioning correctly. It's remote monitoring. We're going to see this. We're going to see, more and more of this remote telemonitoring out there. I think the biggest push right now, what's applicable to what we discussed today, is again this remote monitoring at those central stations and facilities. So, again, using that example of that nurse from Hawaii who said they just implemented this. I mean, it's incredible. So it's a game changer for them because they don't have to spot check a continuous monitor. They don't have to every hour or 2 hours go pop their head into a patient's room. They've got a monitor right in the central core that they can look at, and it tells them the important information that they need. So we're going to see more and more of that tele and remote monitoring.
So we're going to address one more question. Before that, I am showing on screen again the site where you can actually get your CE accreditation certificate. The last question is going to be the following. Are orthopedic patients at more risk due to the use of more pain medication during the post-op phase?
I would not feel confident answering that question. There is a study out there that I encourage this individual to look at. It's called the Prodigy study. It's a prospective multi-center study looking at patients at high risk for opioid-induced respiratory depression. It looked at 1,496 patients across 16 centers in 7 different countries, and it has a risk scoring tool that can serve as a guide for patients at risk for opioid-induced respiratory depression. So I would encourage that person who asked that question to kind of research that study and see what they're finding out. I do not feel confident saying that orthopedic patients are at higher risk than others. There's certainly an argument for that because they do receive opioids, but there's a big push in orthopedics to go opioid free as well.
Perfect. With that, and just to respect the time of everybody, I want to thank all the attendees for your attention to this presentation. I want to thank Philips and Medtronic for the sponsoring of this event, and we hope to see you in future events. Thank you very much and have a great rest of your day.